So we are super happy today to have Dr. Verna Porter. Thank you. Hi, Carol.
Hi.
I'm going to pin Dr. Porter so that she's up there big. Thank you so much for joining us. So this is our seventh of this series, and these are obviously all recorded. And there's been some great health conversations about spine health and about incontinence and hemorrhoids and using CBD. So those are all housed on the YouTube channel or on the Facebook Live. So feel free to do that. If you guys have questions during this, please post them in the chat on the Zoom or in the comments on the Facebook Live, and I'll get Dr. Porter to do that. But for right now, let's kind of get started. So Dr. Verna Porter, she's the director for the program for Alzheimer's disease, dementia, and neurocognitive disorders, which is a whole mouthful, and is, I mean, I guess it's probably kind of a new field, at least in all of the progress that's being made. So Dr. Porter, can you kind of tell us, one, how you get to be a neurologist, a neuroscientist, and kind of what your path was to get there, and then also, what does your practice look like? What kind of patients do you see in a week? How many are women? Kind of how all of that goes. Would you mind sharing that with us?
Sure, of course. And thank you, Tiffany, for having me tonight. I really appreciate the opportunity to talk about this. So I'm a neurologist, and not everybody knows, how do you get to be a neurologist? How does that work exactly? So there's the 4 years of medical school that we all go through. To be a neurologist, you have an additional 4 years of residency, and then I did additional fellowship training on top of that for 2 years, specifically in neurobehavior, neurocognitive, neuropsychiatry, and a little bit of geriatrics. So a lot of things about how does the older brain process information, what is neurocognition, what is dementia, what does normal aging look like, what does abnormal aging look like, how does that manifest in terms of brain health and well-being. And so that was a 2-year fellowship program. I did all of my training over at UCLA, and I was on faculty for UCLA for many, many years. I'm actually professor emeritus for their program as well, and now I'm with Pacific Brain Health. And so essentially now my practice on a day-to-day basis looks very much like older adults in general, not exclusively, but mainly older adults over the age of, I would say, about 55 or 60. I'm seeing them primarily for cognitive disturbances and concerns. So issues about memory, cognitive changes with aging, what's normal, what's not, and a little bit about kind of worried well. And I term that because there are a lot of folks out there where there is a family history of dementia. Mom has dementia, dad had dementia, siblings, something like that. People are worried well, and they want to know what's normal and what's not, and where can they go to get help. And if they do have something like a dementia, I would be the doctor that they come to talk about treatments, interventions, what can be done proactively to help brain health.
Yeah, so that's, I mean,
the whirlwind tour.
I love that. I'm sure that's a question that a lot of people have, as you age, and like, is this abnormal? Is this normal? I can't remember where I put my keys or my coffee cup, and what's normal and what's not. So, I think that worried well part is interesting. So do people usually self-refer, meaning do they just call you, or does their primary care doctor send them to you? How do they get to you?
That's a great question. A lot of people, I would say, are referred, oftentimes through the primary care physician. So usually patients will bring to their primary care doctor a concern like, I feel a little forgetful. I've been misplacing my keys, and I'm forgetting some details of conversations, or oops, I forgot the date the other day. Is that normal? Is that not? And we're seeing maybe a lot more, frankly, in the context of COVID and the pandemic and the social isolation and all the different, kind of psychosocial stressors that people have experienced over this past year, political unrest, all kinds of different things that we've all had to deal with and cope with and kind of get our heads around in various ways. And our brains are still, kind of learning how to do that sometimes, and learning how to rebound from those sorts of events. So, that's kind of, in a sense, what we're doing here is we're trying to take people who are referred from primarily their primary care, but also some are self-referred. Some are coming in and they're saying, gosh, I just have concerns, something's not right, I want to get checked out. Some people are even younger. So I do occasionally see younger people, like in the 30s and 40s, who maybe have concerns about their cognitive functioning or family health history.
That's interesting. So, it's such a big question, and I definitely want to hear about kind of what you do with them. But let's start with some of the big myths that are out there. Like, Alzheimer's disease and dementia are the same thing. Is that true?
No, it's actually not true. It's very interesting. Dementia is what I call the umbrella term. So conceptualize it as like an umbrella, and then under the umbrella, you have different specific diagnoses. Basically, what dementia means is that it's beyond normal limits. It's not typical for age, it's not normal aging. And essentially, what that means is people are outside of the normative range for people, their age, their educational level. So we try to look at kind of a normative base of people and what's typical for, let's say, a 70-year-old. And so if you're outside that normal range, and if your daily functioning is being affected, so you're having difficulty with banking, shopping, cooking, cleaning, driving, these sorts of things, when those sorts of activities start to become impaired, that's really sort of the definition of what a dementia is. But notice I've said nothing specific about Alzheimer's. I haven't used a specific term. So when you make a diagnosis of dementia, it's more of a statement of being beyond normal limits. And then you really have to ask the question, what form of dementia are you talking about? Alzheimer's disease happens to be the most common form. It encompasses about 60 to 70% of dementias. And that's why we hear so much about it. That's why these two terms in people's minds are often synonymous, but they're really not, because there's vascular dementia, frontotemporal dementia, dementia with Lewy bodies, et cetera. So that's kind of where somebody like me as a neurologist comes in, is to try to figure out if somebody's having cognitive changes. Number one, is it beyond normal limits? And number two, if so, what is it? What's the specific diagnosis that you're dealing with? And number three, what's the treatment? What are the options for trying to intervene?
So, the question, and there was one that are these symptoms part of normal aging and they're just happening earlier when you have dementia? I mean, I mean, that's kind of one of those myths that's out there, right? That like the symptoms of Alzheimer's or dementia are just normal part of aging and don't worry about it.
Right, and that's not the case. So dementia really is a pathological diagnosis. It's a medical term. And so this is not just normal aging, and normal aging does not inevitably lead to dementia. So, we've all seen people in their 80s and 90s who are still very cognitively sharp, still very robust, still active and doing what they enjoy and so on. So aging and dementia are not synonymous, just like we were talking about dementia and Alzheimer's are not synonymous. So we have to sort of differentiate. And it's really important that some minor causes of memory change as you age are very normal. Misplacing your keys occasionally, or maybe kind of the word on the tip of your tongue phenomenon, or walking into the room and maybe just for a moment or two forgetting your intent upon going in the room. Those are some normal things that happen to people as they age. But what we're looking for are things that are truly beyond normal limits, that are sustained, that are sort of permeating their daily existence. In other words, these are beyond normal limits. It's not just a day, a moment, an issue, but it's something that's starting to become sort of who they are, and it's changing fundamentally over time. And importantly, it can occur in younger people. So we see patients with dementia under the age of 65. We see patients over the age of 65. Sometimes there are genetic predispositions, sometimes not. In general, younger cases tend to be more genetic. That's not uniformly the case, but they tend to be. People over the age of 65, they're more spontaneous or sporadic cases of dementia.
So you kind of hear this, you talked about the genetic predisposition, and you definitely hear about this a lot. People will say, like, I don't want to know. Like, why would I want to know that that's in my future? So how do you counsel people who are young, who do have parents or grandparents who had dementia or Alzheimer's or something, in that realm? Do you want to know?
That's a good question. So I think that the answer in our minds is yes, you do, because our fundamental paradigm of how we're approaching this is fundamentally changing. Many years ago, even in my late years in training, the kind of the mantra was, this is a neurodegenerative condition. There's not a lot we can do. We don't have a lot of highly effective medications. And it kind of is what it is. And, it just becomes this inevitable process, this degenerative process that you can't intervene with. We now realize that not only can we intervene and are there things that we can do for it, in the disease state, but they're preventative things: diet, exercise, nutrition, brain games, keeping yourself cognitively stimulated, maybe even hormonal support for women. So there are things that can be done to help support brain functioning early on that can help stave off or decrease your risk of developing it. And so if you know a priori that genetically you're at risk, that either you carry a gene or you're concerned you carry a gene because there's a family member who has this, yes, there are things you can start to do even in the 30s and 40s that will markedly diminish and decrease the risk of developing dementia as you age. So we're really beginning to understand that this is a potentially preventable disease. And that's the operative word, it's preventable.
Okay, there's so many questions here. Like, what do you do to prevent it? How do you do the workup? I don't even know where to start. What about the medications? Okay, so let's maybe you want to start with prevention. Like, what are those things that you can do to prevent it? Is this like diet, exercise, cognitive exercise? What are those things?
It's really a number of different things. It's not going to be any one sort of formulaic thing that you can do, but it's kind of, it's being human. And what I mean by that is, a fully realized person is going to be physically active, cognitively active, socially active, emotionally active, somebody who's engaged. And so, yes, cognitive fitness is really important. That means keeping yourself sharp, learning new things, engaging in new activities, challenging yourself as you age, and not becoming sort of stagnant and getting in the rut of, I'm going to do what's comfortable or familiar or what I've already done, but really kind of getting out of the comfort zone and doing things to challenge yourself. So that's one thing. Also, social activity is so important, not only in our immediate families, but larger social circles, meeting new people, being exposed to new ideas and thoughts and so on. That's critical for brain health. And that, again, is kind of a new conceptual understanding. And then we want to be physically active. You want to exercise. You want to engage in aerobic exercise, but also strengthening and conditioning and things that keep you physically fit. But it's really it's the intersection of all of this. It's not just any one thing. So I can't tell you, well, if you go on a stationary bicycle for 40 minutes, 4 times a week, you're good, because that's absolutely important. It's critical, but you really need to do all of these different parts and pieces. And it's only when you kind of pull these things together that you get the optimal synergy for brain health.
So that's interesting. I mean, and it kind of begs the question, like, how do you know? Like, how do you know that being physically active actually helps the brain, or being socially active helps the brain?
Yeah, it's interesting. We've done studies, and actually some of the people in our group through Pacific Brain Health here in Santa Monica have done studies looking at hippocampal brain volume. The hippocampus is a very important memory circuit. It's very deep in the temporal lobe of the brain, and it kind of helps. It's a way station for memories. It helps convert short-term memories into long-term memories, which is critical because that's how we get things encoded into our brains so that we can later retrieve and remember it. So if you exercise, and if you do that well, and if you have good diet, exercise, nutritional practice, social practices, all these things we're talking about, you can actually increase hippocampal brain volume. There is neurogenesis. There is new nerve birth. And that has to be supported by all these things we're talking about. So these things that we're talking about become sort of the milieu, the environment, if you will, that support brain health and well-being and new nerve cell birth and nerve cell genesis and the interconnections of those nerves one to the other. And that's what helps form, kind of the plasticity of the brain that allows us to be novel and engaged and creative and be able to move forward. So we can actually see that happening physically structuring the brain, and we can measure it in research, and we can show in a statistical way that it's significant, that it matters.
That's amazing. So is neurogenesis different based on age or estrogen level or things like that?
Yes, it can be. So when we're young, there's actually quite a bit. There's a lot of neurogenesis, and that does tend to peter a bit as we age. It doesn't stop though. And I have to say that even that understanding has evolved. Like when I was in medical school, this was in the 90s, the teaching was you were born with a certain number of brain cells, you have to, use it or lose it. And if you lose them, they're not going to regenerate. That's it. There's no way to build them back, that kind of game over. And that's not the case. We realize that there's neurogenesis that continues well into, older adults, if not well into the elderly age.
That's so exciting.
Yes, it's very exciting because what it means is it's never too late. It's never too late to start. It's never too late to start to do these things to build that neurogenesis and to support it and to have those new brain connections form. So with that understanding, it kind of opens up this whole new world of prevention and being proactive at any stage of life.
So there's a question in the chat, and it's a really good question, about, like, being challenged is like, your daily work, if you multitask, is that the same thing? Like, what about I can't remember that app. I had it at one point, that does like the brain exercises or mahjong. Like, what
Right. So, I mean, Luminosity, Brain HQ, all those different things, they're all great and they're all very helpful, but it's the novelty. So again, we talk about things like learn a new language, pick up the piano, do these different things that are very challenging. And, that's really, if you think about it, where we're all stretched. Like if I, for example, in my 50s suddenly had to go back and compete with undergraduates at UCLA, to learn something not entirely new, like I decided, oh, I want to learn French. So I'm going to go back and I'm going to study French with undergrads at UCLA who are in their 20s. That's challenging, And so that's that out of your comfort zone that we kind of want to make not just, this kind of mind-blowing concept, but something that people really say, hey, that's different. That's interesting. Maybe I will take a new course. Maybe I will learn something different. Maybe I will take up a different reading strategy, learn different types of things, read different genres than I ever have before. So that's where it's not just, it's not just the multitasking, because if you're multitasking and you're doing the same thing over and over again, every day, it's the same type of multitasking, guess what? That's not really novel, is it? So you've got to go out of your comfort zone. And I think that that's the kind of main message here.
That's a great one. I like that. Just going out of your comfort zone, something that you're like, there's no way I can do that.
There's no way I can do that. And you'd be surprised. You'd be surprised. You can do it.
Can I ask you what the last thing that you took up that was outside of your comfort zone? Because this is like, you're the real deal. Like,
yeah, I'll tell you, I have three boys, one of whom is in college. And so he decided to take some interesting courses about language and the genesis of language, where it comes from, how the brain does that. Well, obviously that's a little bit familiar to me in some ways, but there's also a lot about like Noam Chomsky and the theory of language and how it works and things that I'm not as familiar with. And so I began reading a little bit about it too. And we began to have some interesting conversations. That sort of thing is very intriguing and different, and certainly way out of the zone of where I would normally be talking and discussing on a daily basis.
That's great. Thank you for sharing that.
Sure.
So can you talk a little bit about, you said that 60 to 70% of dementia is Alzheimer's disease. Can you talk about how does this disproportionately affect women, and why we think that is?
It does. So unfortunately, as women, we are differentially affected by this. So for example, about 1 in 6 women over their lifespan will be affected by this disease. In contrast, about 1 in 11 men will be affected by this disease. So unfortunately, there's something inherent about being a woman that just places us at higher risk. And I should say that that's also true for certain vulnerable populations. African Americans are disproportionately affected by this condition. So there are certain kind of vulnerable populations that are at a higher risk of developing this disease than others. And we do have to be aware of that. For women specifically, there are a lot of theories about kind of hormones, estrogen, progesterone, how these various things, especially as we age across our lifespan, how menopause and postmenopause and even premenopause, how this all plays into things like neurogenesis, plasticity of the brain, kind of mood, affect, sleep. All these things are critical for brain health. So as we think about trying to tease out what is it that makes us particularly vulnerable to this disease, we have to think about all these different facets of what make us unique as women and how these changes over our lifespans may influence our vulnerability.
That's great. So I'm getting all kinds of questions on like my text and an email, and we have these myths to go through. But you did talk. Let's kind of I jumped ahead, but in the beginning, if someone does come to you, what is that workup like? Like if I came and I was like,
Right.
I don't really know. I've misplaced things a few times. How do you tell if it's normal aging or abnormal aging?
Of course. So a lot of what I do, we have initial visits, of course. They're usually about 60 minutes, so they're quite intense. And that's just gathering history. It's interviewing the patients. It's talking with an ancillary historian. What I mean by that is maybe a spouse or a family member, somebody who knows the person particularly well. Because guess what? If you're not remembering things, you may not remember to convey your memory loss. So having somebody else who knows you well, who's witnessed and seen some of these changes over time is really important. So it's obtaining a history, it's doing a good physical exam, a cognitive exam by doing some screening tests and measures. And also considering other broad factors that can influence our cognitive functioning, like sleep. Is there a history of sleep apnea? Do you have breathing problems when you sleep that deprive the brain of oxygen? Do you have mood-related changes? Do you have depression? Do you have anxiety? Is that being treated adequately? Are you perimenopausal? And what does that look like? Have you seen your gynecologist? Do you have hormone imbalance that maybe needs to be addressed? All these sort of things kind of have to go into the evaluation and assessment of a patient when we see them. And then depending on what we're concerned about, we may use additional testing like an MRI scan of the brain to look physically and structurally at the brain. Sometimes we'll use a neuropsychologist to do very in-depth and detailed neurocognitive and neuropsychological testing of our patients and compare them to their peers, them versus other people, their age, their educational level, sometimes their gender, to see sort of how they match up and whether things are within the normal range or not. Sometimes we'll use PET scans, which is a functional neuroimaging technique for looking at brain metabolism and functionality. And then blood work, laboratory testing. Maybe some of that is even genetic testing. So there are really a variety of things that go into a very thorough and robust evaluation and workup. But it really starts with a good thorough history, listening to the patient and an ancillary historian, doing a basic cognitive screen, and then evaluating sort of what else may be needed to fill that out.
That's great. That does sound comprehensive. So I guess the next kind of place for us, because we talked about some of the preventative techniques, but one of the big myths is that you hear people say, "Oh, my mom, they diagnosed her with this. She took the Alzheimer's medications, but they aren't working. So she stopped. They're expensive. My insurance doesn't cover it." And so you hear that a lot. So can you talk about like the role of medications and maybe even like how they've changed over the last 5 to 10 years?
Yes, and I would love to be able to talk about how they've changed over the past 5 to 10 years, but the irony of it is we have not had a new Alzheimer's medication FDA approved in a little over 10 years.
Okay.
And so, that's important to recognize. One of the most recent ones that came on market was actually a combined drug, Namzaric, which happens to be a combination of donepezil and memantine put together into a single pill. But the last novel drug that was FDA approved was memantine, also known as Namenda, and that was over 10 years ago. The problem with the current drugs, the current FDA approved drugs that we have, on market right now. So sorry, I think I just lost. Can you all hear me?
I can still hear you and see you.
So sorry. I think we just I lost my connection there. So give me 1 second.
Yeah, that's fine. We can definitely see you.
Okay, great.
So interesting about that. It hasn't really changed in 10 years.
It hasn't really changed in 10 years. And basically, again, we have symptomatic drugs. These slow the rate of progression. So they take a patient from where they are now and they slow the rate of progression. It's kind of like putting the brakes on a car. It slows down maybe how fast the car is going, but it doesn't stop. So it doesn't alter the trajectory necessarily. Unfortunately, this is a neurodegenerative condition, but it's not going to stop or fix or change or reverse the situation. And therein lies the rub. That's the problem. And so that's been the novel hope over the last 10 plus years is, can we get a disease modifying drug? Is there something else we can do? And there have been a variety of strategies that have been tried, oftentimes focused on the amyloid protein, which is this abnormal protein that's deposited in the brains of Alzheimer's patients. So we've had a series of anti-amyloid drugs, many of which unfortunately have failed. One of the most recent and notable ones is aducanumab, and that is still under current FDA review. So the jury's still out on that, but as of December, unfortunately, it was not looking highly promising that would be for sure FDA approved. We'll see. The jury's still out on that. But the point is, we don't have a disease-modifying drug, but the drugs that we do have, the symptomatic drugs, it's still important to take them. They are modestly effective. They do help. They decrease, for example, time to nursing home placement by even up to 5 years sometimes. And that's meaningful for a family. It has positive effects on mood sometimes for patients. So it can help modulate anxiety, agitation, stress. That's important. Sometimes it even helps with relaxation and a little bit with sleep. That's especially important as sleep-wake cycles are deregulated in the condition of Alzheimer's as patients, express this disease. So these drugs do have a role. Plus, there seems to be some synergy between some of these drugs. There's one class of drugs, the cholinesterase inhibitors, and then there's the other class, which is memantine, a single drug, and they do sort of synergize. So by using the synergy, there does seem to be higher potency of these combined type strategies than either drug alone. So definitely patients should be on these drugs. They do have a role. They are effective. They do help. And even on some of the non-cognitive measures like mood, sleep, etc.
Even decreasing time to a nursing home is a huge.
It's a huge thing. It's huge. It's huge for patients and for families and for quality of life, for sure, to keep a
So
patient.
sometimes you're not going to see improvement. It's just slowing the progression of the disease.
Right.
So I guess the extension of that might be, I don't know, you'll tell us, if you know you have a genetic predisposition, but you have no symptoms yet, do you start on the drugs earlier? And are they the same
Oh,
one?
sometimes the drugs are only FDA approved for cases of like Alzheimer's disease or, actual dementia. They're not FDA approved in the setting of mild cognitive impairment, which is kind of a little bit of that gray zone between normal aging and the dementia. We have mild cognitive impairment. The drugs are not formally FDA approved for that particular category, but our diagnostic sensitivity and specificity is rapidly evolving with time. And what that means is we're now at the point where we can take a patient who has mild cognitive impairment, and with a much higher degree of certainty, we can say that we think they have mild cognitive impairment due to underlying or incipient Alzheimer's disease. Now, that's kind of a game changer, because if you know that that pathology is starting in the brain, then if you intervene with these symptomatic drugs early, all the studies have shown the earlier the better, the sooner you intervene, the better. Well, that's a situation in which I think the use of those drugs is very justified and very appropriate. So the sooner the better is my attitude towards that.
Yeah. So if somebody came into you, a woman of a certain age, and said, like, I've misplaced my keys, I can never find my coffee cup after I find it, you're never going to say like, you're silly, that's just normal aging, and head them out the door. At the very least, they're going to get the workup to see if it is normal, and then
Right.
and learn
At the very
something.
least, they would get cognitive screens and evaluations, and we would make sure that there's nothing obvious, like, oh gee, I have untreated sleep apnea and I've had it for 10 years, and oh my gosh, I wonder if that's playing a role. We're trying to look for things like that maybe are subtle and maybe not immediately recognized as being kind of causative factors. So we want to really do that thorough history and evaluation and workup. And although it's wonderful when I can kind of say to a patient, I'm not worried. Let me see you in a year. Let me see you in 6 months.
Right.
We want to be thorough. And I think, again, as our tools are becoming much more sensitive and specific and able to pick up things that are actionable, and I think that's a really important concept, is something that we can actually take action on and do something about. We want to leverage those tools in terms of optimizing cognitive and brain health.
So is there some role, I mean, as you're talking about this kind of seeing patients annually, almost like, from my world, like mammograms, you get them every year so they can see subtle changes. Would someone get cognitive testing every year to find subtle changes?
Yes, potentially. I mean, there's a term that we're bandying about. We call it cognoscopy, like your colonoscopy. So the idea being, yes, maybe we need to be doing these annual screens on people. And so I think that over time, that's going to become more the norm. Now, that may very well start in the primary care physician's office, but I think the idea that we do need to have a sense of baseline and a sense of wellness and brain health assessment in the same way that we do our mammograms and our colonoscopies and the gynecological evaluations and so on. Over time, this should become a routine screening assessment that everybody goes through after a certain age.
Yeah, I mean, I think that sounds great. Okay, so there's a couple of questions, and one of them is about supplements or diet. And I know that Sanjay Gupta just came out with a book about like this whole kind of cognitive stuff, and he talks about, the best diet regimen for the brain. So this, the question in our chat is about turmeric antioxidants. Like, can you talk a little bit about that? And
Yes, I mean, absolutely. So there's a lot in the popular press about this. I'm sure you all have heard also about the book called The End of Alzheimer's by Dale Bredesen. He was a professor at UCLA with the Buck Institute also, and so on. He's put a lot into not just the medical literature, but the research and the popular press about the importance of being mindful about supplements and correcting metabolic disturbances, and kind of doing this 360-degree view and looking at diet, exercise, and nutrition. As far as diet and supplements, I think the general consensus is that it should be guided by science. And what I mean by that is, obviously, if there's a deficiency, if a person has, for example, vitamin B12 deficiency, that's very relevant for cognitive health and well-being. Vitamin B12 deficiency can lead to memory and cognitive problems, changes in mood, even changes in walking and balance. So if there's an identifiable deficiency, obviously repleting that and dealing with that and correcting that is very, very justifiable. I think the area where it gets a little bit more questionable is giving kind of mega dosing on supplements that may have their pros and cons. And some of them really may have cons, and it may need to lead to health effects and problems that are unintended, that are consequences of high dosages of these particular supplements. So a simple kind of blanket approach of take all these supplements in this bag, all shall be well, I don't think that has its role. But I think that there is an increasing understanding of kind of precision medicine when it comes to some of these things, and measuring in an objective and quantifiable way some of these levels, and then repleting when repletion is needed, and doing it in a more measured and scientific way and approach that has great validity and value. So I think that that's more the movement in the field, is to do it in that manner rather than sort of a more blanket, uniform, one size fits all approach to this. And I think the same thing can be said of diet and nutrition too. Like, there's a lot out there. There's the keto diet, and there's the paleo diet, and there's, the mind diet, which is kind of a modified Mediterranean, et cetera. There are a variety of different ways of going about this. And depending on a person's particular health history, health needs, maybe there's prediabetes, there may be other factors in the mix that have to be taken into account when prescribing a diet. So again, it shouldn't be a one size fits all, that the keto diet, if you don't do the keto diet, all is lost. These kind of blanket uniform statements, I think, are where we get ourselves in trouble. And I think, again, a more tailored precision medicine, more measured approach to the recommendations that we make is really going to be more the wave of the future in how we do this.
I think it's so hard, so you shouldn't necessarily do the diet that's at the top of the New York Times bestseller list, but I feel like people are a little torn. They hear all of this stuff, they kind of want to go in a holistic, natural approach. And maybe I don't want what my doctor's telling me, that's a bunch of supplements, vitamins. How do you determine what's the best diet? All these ones that you talked about, who is the best person to help you figure out how to do that? What the best approach is for you?
That's a great point. So we actually engage with a group of nutritionists who have a particular interest and specialty in brain health and well-being, and a knowledge base and training in that. So oftentimes we will actually send, our patients to vetted, registered nutrition specialists and experts to make these kinds of decisions. So even I, as a physician, I'm not trained as a nutritionist. That's not my area or background of expertise. So I want to find colleagues who really do have that as their area of expertise, because there are a lot of subtleties, like patients who have various, metabolic concerns like prediabetes and so on, where you do have to be careful and a bit circumspect about which diets are being suggested. So I think that in some ways, again, utilizing people who really know this area well and can kind of weed through some of the noise, as it were, to be able to figure out what makes sense for a given person. Again, that precision medicine approach to me makes the most sense.
Yeah, I love that. I know there's so many questions. So you guys, please, if you keep putting them in the chat box. There's another one about if you're very symptomatic during menopause, for example, can hot flashes cook your brain? But also, if you've had chemotherapy, and people talk about chemo brain, are there things that predispose you from either the menopause realm of just being a woman or having had chemotherapy for something? Can those predispose you to dementia or Alzheimer's?
Well, I think, unfortunately, we don't know all the predisposing factors that kind of, essentially set this off. We talk specifically now about Alzheimer's. We can't say 100% for sure that there's an absolute well-defined link between hormones and Alzheimer's, but we know that there is a link. And what exactly that is and how that works is still being worked out and evaluated. One of the newer concepts is that there may be sort of a window around menopause during which hormone replacement and supplementation may have value in terms of brain and cognitive health and well-being. And there may be other larger, durations of time after menopause, where if you add hormones, it actually may be somewhat detrimental to cognitive health and well-being. So these things are still being evaluated and defined and researched. So there isn't, a set prescription for how to do this. But I think for a woman who is identifying cognitive changes around the time of menopause, having a good, thorough hormonal evaluation, sort of what we call a pituitary evaluation, the pituitary gland being your hormone gland, has value. And that's not only looking maybe at female hormones, but also at things like your thyroid hormones and cortisol, which is your stress hormone, and other things that may have bearing on sleep-wake cycles and other things that can also influence mood and cognitive functioning. Because around the time of menopause, there are lots of changes that happen in a woman's body, including fluctuations in sleep and wake and other hormones and melatonin secretion and other things in our bodies that probably we need to be more attentive to. So the female hormones are certainly one aspect of menopause and what happens around that time of life, but it's probably not the only thing we need to be considering.
Interesting. That's yeah, there's still a lot to be learned on all this, isn't there?
Yes, absolutely.
Well, I'm so glad that you guys at the Pacific Neuroscience Institute are working on it, because I think it's really impressive, the work that you have done, and I hope that we get a lot more answers. So here's another myth, and I will tell you that I hear something very similar in my world of breast cancer. It's like, oh, no one in my family's had breast cancer, so I won't get it. And it's like, well, it's 80% of breast cancers are random. So can you talk about Alzheimer's disease, and either no one in my family's had Alzheimer's, so there's no way I'll get it, or if one of my parents had Alzheimer's, will I definitely get it?
Right. The first thing to know is we don't know all the genes that control these diseases. And that's true of most diseases that we want to discuss, whether it's breast cancer or Alzheimer's or whatever it may be. There are genes that are continually defined, and we're still trying to understand the human genome. That being said, we have over the years identified some genes that do correlate with higher risk of developing a degenerative condition like Alzheimer's. For example, for older onset Alzheimer's, what I mean by that is over the age of 65, there's the ApoE4 gene, which is more highly correlated with older onset Alzheimer's dementia. If a person has that particular gene, they're at higher risk than somebody who doesn't possess the ApoE4 gene. But the problem is this is imprecise. And what I mean by that is you can have the ApoE4 gene and get the disease. You can also not have it and still get the disease. The majority of cases of Alzheimer's, we believe, are still sporadic, spontaneous. They're occurring without a clear genetic underpinning. And then there are some that are associated with genes. So we really have to kind of consider it in a more holistic way. We can't pin the diagnosis just on genes. Like, for example, I can't send the ApoE4 gene and either you have it or you don't, and then come back to you and say either you have or you don't have the disease. It's not that one-to-one correlation. And it's actually more of a correlation and not what we call a causation. So one does not cause the other necessarily. So they may be associated, and it may swing your risk in a direction, one, either good or bad, but it's not necessarily a determinant gene. And then there are other genes that are associated with young onset Alzheimer's under the age of 65. And those are a little bit more highly genetically linked. In other words, they are a little bit more causative for the disease. So if you have these genes, presenilin genes, other things, you are more likely to get early onset Alzheimer's disease. So there's differential genetic influence of different genes on this particular condition. But just because your parent has it doesn't necessarily mean that you as a son or a daughter will get it. And I think that's the take-home message here, is that risk is determined not solely by genes, but also by things called epigenetic factors or environmental factors, other things that turn genes on and turn genes off, and include things like hormonal factors like diet, exercise, nutrition, all these things we've been talking about that influence the expression of these genes. So environment is very important in terms of determining your relative risk moving forward of getting these, even if you have a genetic predisposition.
Environment meaning things that you can control, or just as you look back on things?
Environment meaning like choices about exercise habits and routines, particularly in midlife, trying to minimize midlife obesity, trying to exercise good dietary practices, good sleep habits, patterns, and routines, minimizing stress and working on stress reduction. These are all the kind of environmental factors that we talk about to try to mitigate relative risk of developing this condition.
So 2020 was bad for our relative risk. So that kind of, you talked about the fully realized person, and Susanna had a question which is kind of based on that, which is, during the pandemic and the shutdown, like what happened to our brains? Like we probably weren't
Yes.
keeping them very healthy with physical and social and no stress and no anxiety
I
and
know 2020 has been horrific for brain health. It's been one of the roughest times, we've gone through in modern history, really, with so many different factors that we all were trying to deal with and cope with. And yes, we are seeing, unfortunately, some of the after effects of patients coming in a little bit more commonly with cognitive and memory complaints at this point in time. But I mean, the flip side, if we can give kind of a little bit of a lining, the silver lining to the cloud, is that our brains are resilient, they are dynamic, and they are plastic, and they are able to change with time. And so hopefully as we emerge out of this, we're going to see a lot of rebounding of people becoming, more social, getting out of their isolated bubbles and kind of expanding their milieu and what they do. But yes, it did take a toll. And so I think it's just sort of yet another affirmation of the importance of environment and what's happening to us and how that can so profoundly affect our cognitive well-being, our mental, emotional, social well-being. Because I think the pandemic was sort of this horrible experiment in a sense that we all had to go through that let us all see on kind of a personal level the impact of what that's like and what happens.
yeah, no, I think that's really true, and certainly everyone suffered on some level from it, and hopefully we all get back and can now focus more on being that fully realized person.
Right.
So you talked. I love the cognoscopy. I thought it's a great term, but so if you're doing cognitive assessments on people who are normally aging, if you could like think into the future about how we do this, where would you start for like the baseline, and is this kind of like maybe you do it at 30 and 35 and 40 and then you start every 2 years and then every year, like how because you have much more knowledge about how the brain ages, so like when would you actually start looking at that, and when would you ramp it up, and like what are
I
those?
think what we're starting to think is that this needs to be evaluated probably in the early 40s, probably around the time of when you transition into the 40s, getting at least a baseline, an assessment of what we call this is going to sound like an odd term, pre-morbid functioning. And that sounds very odd, but what that means is before anything happens, before there's a problem that develops, what were you like at your peak, at your optimal peak performance? What did you look like? What were your cognitive abilities and functions like? And we sort of, in a sense, need to compare against that. Because although there are certain natural kind of declines in our cognitive functioning and abilities that occur over the decades, like for example, my short-term memory is in my 50s going to be the same as it was in my 20s. And that's just unfortunately what we all experience through normal human aging. But what we have to understand is, what can we do to sort of bend the curve and change that a little bit and maybe like make that less likely to occur so that we are keeping things on a more even keel, spectrum. So anyway, I mean, I hope that kind of answers a little bit what we're saying here, but I think we always want to measure against what we think you would have been, where we think you're going. How are you in relation to the curve of where you ought to have been? Are you sort of trending down at a rate that's faster than maybe you should have? And can we get a sense of that measuring you versus yourself and you versus your peers? So those cognoscopies maybe become just that, you versus yourself, you versus your peer group at various age, and then trying to get a sense of what does your particular curve look like? And if you're not on the curve that we anticipate and expect, how do we change that?
And so here's a really irritating question, but we went through this with mammograms, recently when the age changed. Is insurance going to cover those?
I think if it's a basic test, like if it's something maybe like on a tablet, we're talking about an iPad screen or something like that, maybe it's done in your primary care office, maybe it's mailed out, maybe it's an email mailer, maybe it becomes part of kind of your screening assessment that you do before you even go to the doctor's office. If we can do this in a simple, kind of easily digestible format that's simple to administer, then maybe that becomes part of your regular kind of routine physical, as it were, when you go see your PCP, your primary care doctor, once a year.
Interesting. So there was another question, and you talked about this a little bit. The question is like, is it healthier to play video games, that test memory and processing speed? And you talked about luminosity, and like, I think that as those things become routine, they're no longer helping you. But can you
And here's another thing to consider. This is another piece of interesting research data that's come out. There's something very stimulating to the brain about doing something cognitively challenging and physically challenging at the same time. There's a synergy. And so we have what's called a CogFit health brain wellness gym, essentially, here at Pacific Brain Health. And what we do is we actually simultaneously challenge the brain through various video games and various mechanisms to cause people to have to do things cognitively while they're physically engaged, like on a bicycle or on a treadmill, or having to do some stair step maneuver or something like that. There's something about the synergy of that that is actually more challenging to the brain and increases neurogenesis at a faster rate than either doing one or the other alone, or even doing it sequentially. So being on your treadmill, reading your book, or having that conversation with your family member, doing something cognitive and physical simultaneously seems to work better than just sitting there passively, just doing the brain games. So just something to consider. So when you're on your treadmill, do something cognitively stimulating. When you're walking, when you're doing your evening walks or your exercise or whatever it is, bicycling, can you possibly add to that a cognitive task? Because that would actually be the most challenging.
So I've heard about your CogFit lab. I've never been. It's the floor below me. I think I just need to go every day, every other day, and get that in there. So what if people wanted to try that and do it? Because I know I saw it
We actually have a program. We have a program that people can sign up for, just like you would sign up for a gym, basically, that is available. The unfortunate problem is it's not covered by insurance.
Right.
And unfortunately, as I'm sure most people can anticipate, in the same way that your gym, going to a gym, even though it has profound health benefits, it's not covered by insurance. Hopefully, maybe someday it will be, because it's very, very preventative for brain health and maintaining brain health and well-being. But just like you would sign up for a gym, you would sign up kind of to do this as well. And obviously, we try hard to keep the costs very, nominal and so on as best we can. But this is something where it is kind of like a program that you would sign up for outside of the confines of your insurance coverage.
That's great. And again, so this is through Pacific Neuroscience Institute, which will put all of the Dr. Porter's information on the Facebook page for the Women's Health and Wellness Institute and for Pacific Neuroscience, so that you kind of know where to go. They have some amazing programs and clinicians there. So there's a couple more questions. We're kind of getting down to the last minute. So if you guys have questions, put them in. So there's another one about kind of the hormone function, so thyroid, endocrine functions. Is this something that your doctor should raise with you, your primary care, or is this when somebody comes in to have a cognitive exam with you?
This is something that oftentimes typically is raised by the primary care physicians. There are situations in which maybe it hasn't been raised, and then we would try to sort of fill in those gaps and so on. And, kind of our hormone panel, as it were, the things that we're starting to look at over time has expanded. Even during the past 5 years, the kind of things that I'm looking at more routinely as a screening tool were not things maybe that we thought about as much even 5 years ago. So this is process and evolution. And it's really understanding what are the important kind of touchstones that we need to look at in terms of brain health and hormonal health and, pituitary brain functional health. So that neuroendocrine system, which influences so many different organs in the brain, not just your brain, but your heart, your muscles, all kinds of different things, all of which becomes important because, for example, if you can't exercise, that influences your brain. So if your muscles aren't strong, that influences your brain. If your heart isn't strong enough for your cardiovascular health to withstand cardiovascular aerobic exercise, that harms your brain. All these things tie together. So we do have to kind of think about these things and how they're going to influence overall brain health and your ability to be cognitively, physically, socially engaged, as we've been talking about.
So as part of your cognitive workup, you would always do a hormone panel on someone.
Yes, we would typically always, for example, look at thyroid panels. That's always included. And then again, depending on the age of the woman, looking, for example, at female hormones in somebody who's 85 may quite honestly have a lot less value than somebody who's perimenopausal. So it does depend on the age of the person and what we're trying to think about in terms of that particular age group, what's relevant, what's, again, actionable. I think that's an important word, because in medicine, we're not just gathering data for the sake of gathering data. We're trying to have actionable pieces of data that we can react to and do something proactive with. So I think it is sort of tailor-made based on the person, the presenting complaint, what the current issues are, and so on. But there are certainly things like thyroid that we check in pretty much across the age span.
And what about part of the question also is vitamins? Like, should you get your B12 levels tested annually? Like, is that something that's that you guys always do? And should they be asking their primary care doctor for that?
Right. So B12, kind of the same thing applies, that when you're younger and your gastrointestinal system is working well, B12 deficiency is really relatively rare unless there's some very unusual dietary practices and habits. But in a younger person, the gut absorbs B12 well, and it's rather rare to have a B12 deficiency syndrome. As you age, that becomes much more common. So certainly as people are aging, if they're presenting with memory concerns and problems, B12 should be sort of a knee jerk. That should be sort of a test that's absolutely checked as a knee-jerk reaction to any complaint of cognitive or memory changes. So that would be one that, yes, I would think that a PCP, a primary care doctor, would probably be checking that first. And an older person with a memory complaint, we would absolutely be checking that as a routine practice.
That's awesome. And then can you tell us about something that's exciting that's going on at PNI, either your research or something that you're part of? I think that's always exciting for people to hear about.
Absolutely. There's several things. I mean, we are not only a clinical program, we are also a research entity. So Pacific Brain Health, we have an entire team of researchers, PhDs, research assistants, et cetera, that help to run our clinical trials and our various programs. So we have a variety of things that we're doing. One that I'm very excited about is something called the prevention trial. And it's looking at patients either with mild cognitive impairment or mild forms of Alzheimer's disease, and utilizing all of these lifestyle interventions that we've all been talking about to see the impact of that on disease trajectory. And again, whether we can sort of bend the curve and make their outcomes better in terms of better, more robust brain volumes, better cognitive functioning, better physicality, all those measures. So we're looking at things like diet, exercise, nutrition, hormones, all these different precision medicine factors. We're trying to optimize all of that. We're trying to connect them with nutritionists, exercise coach, lifestyle coaches. So we're looking at sort of the active limb, which is these kind of very holistic and somewhat aggressive interventions where you get the full coaching, if you will, to make all this happen. Because it's one thing to say, do this, another thing to have somebody who's helping you to make it happen versus the more conventional care, and then seeing kind of the difference in how those patients do over time. So that's just one example, one clinical trial that's ongoing right now for which we're actively recruiting subjects. And that's very exciting. And we're doing that in patients whether they're on conventional FDA-approved drugs or not. So they can be on, donepezil, they can be on memantine and things like that, and still participate in this trial. So it's sort of, in my mind, added benefit. And we're not dealing with an investigational, frightening drug. This is something where, these are things that benefit not only brain health, but cardiovascular health and just mood and overall well-being. So that's one thing. But we're also doing things like stem cells. This is being done through the St. John's Cancer Institute. There is a stem cell trial that's going to open for patients with mild Alzheimer's disease. So that's very exciting. We have something called the MSIM study, which is for mild cognitive impairment, mild memory loss, or what we call amnestic mild cognitive impairment, where patients get an iPad and they're instructed on doing various physical cognitive activities in their own homes. So that's going to be a trial that's opening. We've done trials even that have involved caregivers, that have looked at caregiver mood and cognitive resilience and stress reduction, and how that ultimately benefits patients. So if your caregiver is doing well, the patient's going to do better. So if your caregiver is less stressed, less anxious, less sleep deprived, et cetera, ultimately, that translates into better care for the patient. So a variety of things like that are ongoing, and many more, still to come down the pike.
I love that. That's just some amazing work that you guys are doing, and I know that everybody learned so much today. That was really appreciate you taking your time. You're obviously very passionate about this and knowledgeable, and we all really appreciate your time and sharing that with us.
Well, it's my pleasure, and it's a pleasure to be involved in kind of a women's forum too, because again, this is a disease that differentially affects women, and I think it's really good that we're all kind of coming together. Thank you, Tiffany, for having this opportunity for us all to speak like this on various topics that do benefit women.
Absolutely. Absolutely. All right. Thank you so much, Verna. Good night, everyone. Good to
Thank
see
you.
you. Take care.
Bye-bye.
Bye.